Welcome to this lecture on Kawasaki disease based on the essentials of pediatrics from Nelson 2023 edition. In this session, we will discuss the definition, clinical features, diagnosis, treatment, and complications of this important pediatric vasculitis. Kawasaki disease is an acute febrile illness primarily affecting young children under the age of 5. It is a medium vessel vasculitis with a predilection for the coronary arteries. It is more commonly seen in boys and in children of Asian descent, particularly in Japan. Importantly, it has now become the leading cause of acquired heart disease in children in many developed countries, surpassing even rheumatic fever. The exact cause of Kawasaki disease remains unknown. However, it is believed that an infectious trigger, likely viral, sets off an abnormal immune response in genetically predisposed children. This results in widespread inflammation of medium-sized arteries, especially the coronary arteries, making cardiac involvement the most critical concern. The diagnosis of Kawasaki disease is clinical. The hallmark is a fever lasting at least 5 days, along with at least 4 of 5 principal features. Bilateral conjunctival injection without exudate, oral mucosal changes like strawberry tongue, a polymorphous rash, extremity changes such as edema or peeling of the skin, and cervical lymphadenopathy, usually unilateral and more than 1.5 centimeters. Incomplete Kawasaki disease should be considered in children, especially infants, with prolonged fever and fewer than 4 diagnostic criteria. Lab findings such as elevated inflammatory markers, anemia, low albumin, thrombocytosis, and sterile pyuria may support the diagnosis. Echocardiography is crucial to evaluate coronary involvement. The most feared complications of Kawasaki disease are cardiac. If untreated, up to 25% of children develop coronary artery aneurysms. Other cardiac complications include myocarditis, pericarditis, valvulitis, and arrhythmias. Long-term risks include myocardial infarction and sudden death due to these vascular changes. The cornerstone of treatment is intravenous immunoglobulin, given at 2 grams per kilogram over 10 to 12 hours. Aspirin is also used initially in high doses for anti-inflammatory effect and later in low doses for its antiplatelet action. Echocardiography is essential for monitoring coronary artery involvement. In cases resistant to IVIG, corticosteroids may be added. With early and adequate treatment, most children recover without long-term issues. However, coronary aneurysms may persist in some, necessitating long-term cardiology follow-up. Early diagnosis and treatment significantly reduce the risk of serious complications. To summarize, Kawasaki disease is an acute febrile vasculitis that primarily affects young children. Diagnosis is clinical, supported by labs and imaging. Prompt treatment with IVIG and aspirin is crucial to prevent coronary complications. Monitoring and follow-up are essential for a favorable outcome.